about aim 2 of the Worries and Concerns project. I did hold a coffee morning as we spoke about back in August, September, around aim 1. So if we just remind ourselves, UHS is part of a 7-wide hospital collaborative series, which is funded by the NHS England. And in our project, we've got 2 aims. The first is how to implement spread reliable methods for patients or their families, carers, to escalate worries and concerns about acute illness and deterioration when standard care is not meeting their needs. And aim 2, how to implement and spread reliable methods for patients and their families, carers, to routinely input their views regarding their wellness trajectory and any worries or concerns into the health record, with evidence that those worries and concerns are considered and acted on by the healthcare team. Oh, did we lose John?
No, we've gained a John, actually.
We've
got 2 Johns.
Hello, second John. Hello, my name's Emma, and I'm just we've just started, so welcome.
I'm sorry I'm late.
No, not at all. Thank you for joining us. I'm going to leave this up on the for a moment and allow John number 2 to read it for himself. But essentially, how these aims rather are being put into practice, with aim 1, which is the aim that we focused on pretty much from the get-go, because we felt that it was probably the most challenging and we felt it had the best return for that time and money investment. And so we've set up a new patient safety service off the back of aim 1 called Call for Concern. And I'll update you a little bit more about that as we go on. The focus of this morning's coffee morning is to talk a little bit more about aim 2, which has only recently kind of come to the fore now that we've got aim 1 up and running a little bit more. So we're starting to focus a little bit more on that aim 2, which is how to implement and spread reliable methods for patients to routinely input their views. So the Call for Concern service update, so this relates to aim 1. Call for Concern is a new patient safety project. The pilot launched in October 2023. In essence, what Call for Concern does is that it gives patients, carers and their relatives the ability to self-refer to the critical care outreach team if they suspect that the patient is experiencing a deterioration in their physical health. And why has this been a concern? Well, it's because we know that for all the good that we are doing in the NHS widely, that there are still instances where we're not either identifying or responding to deteriorating patients in a timely manner. And there have been some very high profile cases where sadly, particularly children, have ended up dying or having life-changing injury as a result of their deterioration not being identified and responded to quickly. So I don't want to focus too much on Call for Concern because it's kind of out there and it's coming out hospital-wide and see from March. So I'm busy at the moment getting Cancer Care MOP, which is medicine for old people, getting those care groups on board, and then we're going for a big bang rollout come March, and it will be hospital-wide, and there'll be a mixture of internal and external communications, advertising it to staff and obviously patients. The way in which Call for Concern works is that if you have a concern about yourself as the patient or a relative who is an inpatient, then you have the phone number for the hospital, the main phone number that takes you through. I always say reception. It's not reception. It's the oh, Barney, help me out. My brain's gone confuzzled.
Some sort of switchboard?
Switchboard, that's the word.
Yep.
Honestly, every presentation. It goes through to switchboard. Switchboard then put it through to the hospital site team. And what the site team do, if you can imagine it in terms of aviation, the hospital is the airport, and the site team are the control tower. So they've got oversight as to what's happening in the hospital. They are very high level decision makers. They're the people that get stuff done. And so the phone calls go through to them to be triaged. And that's because, one, we don't want the critical care outreach team having to triage inappropriate calls and referrals, clogging up their time, because, you know, I sit in the critical care outreach office, and honestly, on the days when there's even 2 or 3 members of staff on call, you could double that and still not meet the demand around the hospital. So we don't want our staff tied up in phone calls, you know, trying to resolve issues that have nothing to do with patient deterioration. So you will hear more about that as patients, as it rolls out across the hospital. But as I said, today we're focusing on AIM 2, which is inserting the patient voice in their care trajectory. And so the way in which we and most of our colleagues in the collaborative series are going about this is to introduce a patient wellness questionnaire. Now, when we think of the word questionnaire, we sometimes think of a very long form, which, you know, will take forever to fill out. And it's not that at all. I'm just going to swap screens for a moment to give you an example of what it looks like. So bear with me if I can get out of this. Different window. I'm going to stop presenting a moment because there we go. I'm just going to show you what that looks like in practice. So this is the accessible version that I'm showing you. And this is a prompt that nurses can use if patients have communication issues. But it also shows you the 2 questions that we will be asking patients. So how are you feeling today in terms of your physical health? And it's a very simple, better, worse, the same. And then a follow-up question with, how are you feeling compared to when we asked you yesterday? Better, worse, the same. Now, I know what you're thinking. That seems really quite rudimentary. But the thinking behind this is to really offer a springboard for those more granular, detailed conversations. Because the one thing that it has become clear that we're not doing regularly is actually asking our patients how they're doing and documenting it. And so what we need to get to is that formalization of documenting regularly both patient or their families' input into how they feel the patient is doing in terms of their recovery or their wellness. The emojis are there, as I say, to support communication. And so really what I'm looking from you guys for today is to kind of put yourself in the position of an inpatient about how you may feel if you're on a ward where these patient wellness questionnaires are in practice, how you would feel in terms of being asked what you're being asked, why you're being asked it, and also about the metrics that we're taking. So these are the measurements that we're using. So the data that we will be looking to take away and use in these questionnaires is your patient number, your length of stay, obviously your answers to the question. It will be a daily question, so there will be a daily update. We will be looking at when in your care pathway may you have activated a concern. And what we mean by this is if you answer, well, I'm feeling worse than I felt, then that's a concern. Or if you say, well, I'm feeling the same, but your nursing staff would have expected you to have started to feel better at this point, that is a concern. And so what we're looking to do with those metrics is to understand whether or not patients and their families are able to detect deterioration before patients start to show physiological symptoms. And that is because we know as healthcare professionals, there are soft signs of deterioration. And a soft sign might be something as simple as, the patient's more irritable or more sleepy or more agitated. And this is particularly relevant for our patients for whom communication is difficult or who may present with learning disabilities or challenging behaviours due to mental health. It's about getting used to, one, talking to our patient and understanding that actually behaviour or emotion can sometimes be an indicator of a physiological issue. So we're very keen to support our patients with accessibility needs as part of this. And the benefit to patients will be that nursing staff will become more able to recognise and react to those softer signs. Now, you might ask, well, what can we do if a patient is showing a soft sign of deterioration, but isn't yet showing a physiological symptom? Well, we can't treat what we can't necessarily see, but what we can do is that we can alter perhaps how often that patient is having observations. We can maybe consider environmental factors. We can consider their history and whether or not this change of perhaps behaviour, they've become more irritable or more sleepy, or well, when that happened before, it was a sign of infection or a sign of pain or discomfort. And so it's about getting to know the whole patient and really taking a very holistic approach. Now, in terms of a feasibility of scaling up to make this a hospital-wide practice, that is something that we are still working on. And IT being what it is in the NHS, we are struggling at the moment to find a digital solution to make this a reality hospital-wide. So we are very much in a pilot phase and we'll be starting that in the next few weeks. It does, however, link to Martha's Rule, which may be something that you are familiar with. A young girl called Martha died of sepsis at King's College, sadly, about 3.5 years ago now. And her mother in particular has been campaigning for what they term Martha's Rule, which is the right to a second opinion. So all of this is kind of interlinked, but what the patient wellness questionnaire, how it links to Martha's Rule, is that we are formally recording the patient or the family's response to issues around deterioration or potential deterioration. And why that's important is that throughout Martha's case, when she was starting to show signs, both soft and very obviously clinical signs of deterioration, her parents did raise alarms. They did constantly speak to medical staff about these new symptoms and what that might mean for Martha. And they felt very much not listened to. They felt their concerns were not taken on board. And so what we want to make sure is that patients do not feel that they're not being listened to. We want patients to feel that they have a voice and they have agency and they are empowered whilst in our care. So the last page was kind of thoughts, feelings, questions.